All right, let's dive into peripheral nerve anatomy and injury. We're going to break down how these nerves work, what happens when they get damaged, and how the body tries to fix things.
Perfect.
You ready?
Let's go.
Okay, so at the most basic level, what is a peripheral nerve?
Well, you can think of a peripheral nerve as a collection of axons, which are like wires that carry signals throughout the body.
Okay.
Some of these axons are covered in myelin, which acts as insulation and allows for really fast transmission of signals. Others are unmyelinated, so they transmit a little slower.
Gotcha.
When a myelinated axon is injured, a process called Wallerian degeneration kicks in distally. Basically, the part of the axon beyond the injury breaks down.
Right.
Then the nerve tries to regenerate, sending out sprouts from the cut end. There's this structure called a growth cone that guides the regenerating axon, and Schwann cells, which are supporting cells in the nerve, come in and try to remyelinate these new fibers.
Fascinating. So let's break down the structure of a peripheral nerve. What are the key components?
Think of it like a cable, like an electrical cable.
Yeah.
The individual wires are the axons. Each one is wrapped in a thin layer called the endoneurium.
All right.
These wires, or axons, are bundled into groups called fascicles, and each fascicle is surrounded by another protective layer called the perineurium.
Okay.
Then, a bunch of these fascicles together form the entire nerve, and that's encased in the outer layer, the epineurium.
So it's kind of like a hierarchy of structures.
Exactly. And remember those Schwann cells we talked about? They're really important because they're the ones producing the myelin,
Right.
and the gaps in that myelin sheath, the nodes of Ranvier, are essential for that fast jumping conduction we see in myelinated nerves.
So zooming out a bit, from a surgical perspective, what are the most important things to remember about this structure?
Well, the fascicle is the smallest unit we can realistically work with during surgery. The epineurium is often what we end up suturing when we're repairing a nerve.
Makes sense.
And don't forget about the mesoneurium. That's the loose connective tissue around the epineurium, and it's super important because it allows the nerve to move freely without being stuck.
Ah, okay. And of course, these nerves need a blood supply. So how does that work?
They get their blood from arteries called arteriae nervosum or vasonervosus. These arteries run along the nerve and branch off within the epineurium, forming a network of blood vessels.
I see.
This network then supplies the capillaries in the perineurium and the endoneurium, bringing nutrients and oxygen to the nerve fibers. This whole microcirculation system is actually pretty delicate and vulnerable to pressure, which is something we have to keep in mind, especially with compression injuries.
That makes sense. Now, we've talked about the typical structure, but there are some variations, these anastomoses, that can make things a bit more complex, right?
Oh, absolutely. Anastomoses are basically connections between different nerves, and they can sometimes make it tricky to figure out exactly where an injury is or how bad it is.
Can you give an example?
Sure. The Martin-Gruber anastomosis, for example, is a connection between the median and ulnar nerves in the forearm. And then there's the Rich-Canu anastomosis, which connects those same nerves but down in the hand.
Okay.
There are a couple of others too, like the Froment-Robber and the Berrettini connections, but those are less common. The key takeaway is that we have to be aware of these potential connections so we can get an accurate diagnosis.
So let's go back to what happens when a nerve is injured. We talked about Wallerian degeneration, but what else is going on at the cellular level?
Right. So besides that breakdown of the axon distally, the neuronal cell body, which is the main part of the nerve cell located back up the nerve, might start showing some signs of stress, and that's called chromatolysis.
Interesting.
And as the nerve tries to grow back, the growth cone at the tip of the regenerating axon is super active. It explores its surroundings and uses chemical signals to try and find its way back to the original target, the muscle or sensory receptor it was connected to.
So it's like it's sniffing out the right path.
Yeah. Exactly. But it's not always perfect, and sometimes those initial connections aren't quite right. It takes time and the right environment for the nerve to fully recover.
So you mentioned chemical signals. I've heard the terms neurotropism and neurotrophism. What's the difference between those two?
Neurotropism, that's basically guidance. It's those signals that attract the regenerating axon toward its target. Think of it like a map.
Okay.
Neurotrophism, on the other hand, is more about nutrition. It's the ongoing support that the axon needs to survive and grow properly once it reaches its destination. So you could think of it like food and water.
So neurotropism is getting there, and neurotrophism is staying alive and thriving.
Precisely.
Makes sense. Now, what about the concept of a double crush injury? What does that mean?
Well, the idea is that if a nerve is already compressed somewhere along its course, like in the carpal tunnel, for example, it might be more susceptible to injury from another compression further down the line.
So it's like the first injury weakens it.
Exactly. That initial compression can compromise the nerve's overall health, making it less resilient and more likely to be affected by even a minor second compression.
Interesting. So let's talk about the main causes of peripheral nerve injuries. What are the most common culprits?
It really boils down to three main things. Compression, which is when something presses on the nerve, tension, or stretch, when the nerve is pulled too far, and then direct cuts or lacerations where the nerve is actually severed.
Makes sense. Now, let's say a nerve is severely damaged. What happens to the muscles it normally supplies?
Well, if a muscle loses its nerve connection, it's basically cut off from the signals that tell it to contract and function. This is called denervation.
Mm.
Without that input, the muscle fibers start to shrink and waste away, a process called atrophy. And as time goes by, that muscle tissue gets replaced by scar tissue, which is called interstitial fibrosis.
So the muscle essentially withers away.
In a way, yes, and the longer it stays denervated, the less likely it is to recover.
So is there a window of opportunity for these muscles to be reinnervated?
Generally speaking, the best chance for a muscle to regain function is within the first 3 months after the injury.
Oh, wow. So that's a pretty tight time frame.
It is. You see, those regenerating nerves, they grow at a rate of roughly 1 millimeter per day. So the further the distance the nerve has to grow to reach the muscle, the more critical that early window becomes. After about a year, it becomes much less likely for that muscle to regain full function. And of course, things like age and overall health can also play a role in recovery.
So the clock is ticking. What about sensory recovery? Is that any different?
Well, younger patients tend to have better outcomes when it comes to sensory recovery. It's not entirely clear why, but their nerves seem to have a better ability to regenerate and reconnect. And it's not just the original nerve fiber that can contribute to this. Sometimes nearby healthy axons will sprout new branches and help reinnervate the affected area, sort of picking up the slack.
So there's a bit of teamwork involved.
Exactly. But if a nerve repair is delayed for more than a year, the chances of getting back full sensation are slim. In those cases, we often just aim for protective sensation, which means the patient can feel enough to avoid further injury, but they might not have the same level of fine touch or discrimination.
That makes sense. Now let's talk about how we categorize these nerve injuries. You've got Seddon and Sunderland's classifications, right?
You got it. Seddon's classification is kind of the classic way of dividing these injuries. It's based on the severity of the damage. So you've got neuropraxia, which is the mildest form.
Okay.
In neuropraxia, the nerve is basically stunned, like a temporary block, but the axon itself is still intact.
So it's like a pinched nerve?
Sort of. Then there's axonotmesis, which is more severe. Here, the axon is actually damaged, but the supporting structures around it, the endoneurium and perineurium, they're still okay.
Okay.
And finally, you've got neurotmesis, which is a complete severance of the nerve all the way through.
So that's the most serious.
Absolutely. Now, Sunderland's classification expands on Seddon's a bit. It's a 5-degree system that takes into account the different layers of the nerve and how they're affected.
That sounds more detailed.
It is. So, first degree Sunderland is like neuropraxia, a temporary conduction block. Second degree involves axon loss, but the endoneurium is preserved, and that usually has a good prognosis for recovery. Third degree, you've got damage to the axon and the endoneurium, so recovery might be incomplete. Fourth degree involves damage to the axon, the endoneurium, and the perineurium, so you're going to see more significant deficits. And then fifth degree is like neuromesis, a complete nerve division, which generally has a poor prognosis without surgical intervention.
Wow, that's quite a range. So in a clinical setting, how do we go about diagnosing these injuries?
It all starts with taking a good history, really understanding how the injury happened, and then doing a thorough physical exam.
Right.
We're looking for any loss of sensation, muscle weakness, or abnormal reflexes. There are a few specific tests we can do as well.
Like what?
Well, there's Tinel's sign, which is when you tap along the course of the nerve and it causes tingling or a pins and needles sensation in the distribution of that nerve.
I've heard of that.
Yeah, that can indicate that the nerve is regenerating. Then there's 2-point discrimination, where we check how well the patient can distinguish between 2 points touching their skin. That gives us an idea of the density of sensory nerve endings in the area.
So the closer the points they can feel, the better the sensation.
Exactly. We also check vibration thresholds, how well they can feel a vibrating tuning fork, and Semmes-Weinstein monofilaments, which are these little nylon fibers that apply a specific amount of pressure. Those help us assess pressure sensation, which is particularly important for compression injuries. And of course, we look at how well the patient can perform everyday tasks like buttoning their shirt or picking up small objects. That gives us a sense of their functional limitations.
So it's a very hands-on approach.
Definitely. And then we have electrodiagnostic studies like electromyography or EMG and nerve conduction velocity tests or NCV.
What do those tell us?
These tests measure the electrical activity in the muscles and nerves. They can help us differentiate between different types of nerve injuries, determine the severity, and see if there's any evidence of nerve regeneration. They're usually done a few weeks after the injury to give the nerve time to show any changes.
So if surgery is needed for an open nerve injury, like a deep cut, are there different timelines for repair?
Yes, the timing of the repair is really important. The ideal situation is a primary repair, which means we fix the nerve within 24 hours of the injury.
So as soon as possible.
Exactly. That gives the best chance for the nerve ends to heal together properly. But sometimes, if the wound isn't clean or there are other injuries that need to be dealt with first, we might do a delayed primary repair, which is within a week of the injury.
Okay.
And then if it's been more than a week, we're talking about a secondary repair. And that can be more challenging because the nerve ends might have retracted and there could be more scar tissue forming.
So the earlier the better. What about closed or blunt injuries where the nerve isn't exposed? How do we manage those initially?
In those cases, we usually start with a period of observation. We might do some initial electrodiagnostic studies, but then we typically wait around 6 weeks to see if there are any signs of spontaneous recovery.
So give it some time to heal on its own.
Exactly. And then we reevaluate around 12 weeks, looking for clinical signs of improvement and possibly repeating those electrodiagnostic studies. If there's no evidence of recovery by 3 months or so, then we might consider surgical exploration to take a look at the nerve directly and see what's going on.
Okay, so let's talk about the actual surgery. What are some of the key technical considerations during a nerve repair?
Well, first and foremost, we need to do a really thorough assessment of the nerve before and after the repair. We use microsurgical techniques, which means operating under a microscope with very fine instruments and sutures.
So it's very delicate work.
Oh, absolutely. Precision is key here. Whenever possible, we try to do a primary repair, which means bringing the two cut ends of the nerve back together directly. But to do that, we have to make sure there's no tension on the repair.
Why is that so important?
Because if there's tension pulling on that repair, it's going to put stress on the nerve and it won't heal properly.
I see.
So if there's a gap between the nerve ends, we might need to use a graft or a conduit to bridge that gap and allow the nerve to regenerate without tension. And after the surgery, we have to be careful about how we position the limb. We want to avoid extreme movements that could stretch or put pressure on the repair.
It's like protecting a delicate seedling.
Exactly. And then, of course, we have to plan for rehabilitation, both for sensory and motor recovery.
Right. Now, you mentioned different types of repair, perineural and epineural. What are the main differences between those?
So perineural repair, that's when we suture the perineurium. That's the sheath around individual fascicles or small groups of nerve fibers.
Okay.
The idea there is to try to get a more precise alignment of those regenerating axons. However, it can be more time-consuming, and there's a slightly higher risk of scarring within the nerve. Epineurial repair, on the other hand, is simpler. It just involves suturing the outer layer of the nerve, the epineurium. It's quicker and often gives comparable results, especially for smaller nerves like those in the fingers.
So it's a trade-off between precision and simplicity.
You could say that. And sometimes the choice depends on the specific nerve, the location of the injury, and the surgeon's preference.
Okay, so when there's a gap between the nerve ends that can't be closed directly, what are our options besides grafting?
Well, one option is neurotization. That's basically when we borrow a nerve from somewhere else, a nerve that's not as critical for function, and we use it to re-innervate the target muscle or sensory area.
So we're redirecting a nerve.
Precisely. We can also try to mobilize the nerve, carefully freeing it up from surrounding tissues to gain some extra length, but there are limits to how far we can stretch a nerve without damaging it.
Right, you don't want to make things worse.
Exactly.
Hmm.
And in some cases, like around the elbow, we can transpose the nerve, moving it to a slightly different path to shorten the distance it has to travel. And in some very specific situations, we might even consider shortening the bone to bring the nerve ends closer together, but that's usually a last resort because it can have other implications for function.
Makes sense. So you mentioned nerve grafting for larger gaps.
Yeah.
Can you talk about the different types of grafts and when you might choose one over another?
Sure. So when we can't bring those nerve ends together directly without tension, a nerve graft is often the best solution.
Okay.
And autografts, which is where we use a piece of the patient's own nerve from somewhere else in their body, those are considered the gold standard. The sural nerve, which runs down the back of the leg, is a common donor nerve.
So we're essentially robbing Peter to pay Paul.
In a way, yes. But the sural nerve is often expendable because it mainly provides sensation to a small area on the outer foot. And in cases where there's a lot of scar tissue or poor blood supply in the area of the nerve injury, we might use a vascularized nerve graft. A vascularized nerve graft, it's basically a nerve graft that brings its own blood supply with it. We take a piece of nerve along with its accompanying artery and vein, and that helps ensure good blood flow to the graft.
So it's like a self-contained unit.
Exactly. There are a few different donor sites for vascularized nerve grafts, depending on the location and size of the gap that needs to be bridged. And for small sensory nerve gaps, sometimes we can use a vein graft.
You mean like a piece of vein?
Yeah, we can take a small segment of vein from the arm or leg and use it as a conduit for the nerve to grow through.
Interesting. So the nerve essentially uses the vein as a tunnel.
Precisely. However, vein grafts don't always work as well as nerve grafts, especially for longer gaps. And then there are allografts, which are nerve grafts from donors.
So like an organ transplant.
Similar concept. But allografts require special processing to remove the donor cells and minimize the risk of rejection. And even with that processing, patients often need to take immunosuppressant medications for a while to prevent their body from attacking the graft. There are also processed nerve allografts, which are basically allografts that have been further treated to remove as much of the donor tissue as possible. Those can be useful for certain types of sensory nerve gaps. And then finally, we have synthetic nerve conduits. These are artificial tubes made of materials designed to guide nerve regeneration.
So instead of using a natural nerve, we're using a man-made structure.
Exactly. Synthetic conduits can be an option for short nerve gaps, especially in less critical sensory areas. And sometimes patients prefer them because they don't involve taking a nerve from somewhere else in their body.
Makes sense. You mentioned nerve transfers earlier. Can you explain a bit more about what those are and when they're typically used?
Sure. So a nerve transfer is basically when we take a working nerve, one that's less critical for function, and we reroute it to take over the function of a damaged nerve.
So it's like a rewiring job.
Yeah, you could think of it that way. We're essentially sacrificing a less important function to restore a more important one.
When would you typically choose to do a nerve transfer?
Nerve transfers are often considered in situations where a direct repair or a graft isn't feasible. For example, in brachial plexus injuries, where the nerves that control the arm are damaged near the spinal cord, or in proximal injuries, where the injury is high up on the limb and the nerve has a long way to regenerate.
Okay.
They can also be useful in cases where there's a lot of scar tissue around the injured nerve, making a direct repair difficult. And in older injuries where the muscles have been denervated for a long time, a nerve transfer might offer a better chance of restoring some function.
So it's a more complex procedure, but it can be a valuable tool.
Absolutely. And there are many different types of nerve transfers depending on the specific nerves involved and the desired outcome.
You also briefly mentioned endoside nerve repair. Can you elaborate on that a bit?
Sure. End-to-side repair is a technique where we connect the end of a damaged sensory nerve to the side of a healthy nerve.
So we're kind of tapping into a working nerve.
Yeah, that's a good way to put it. The idea is to try to get some of those regenerating axons from the damaged nerve to grow into the healthy nerve and restore some sensation.
Does it work as well as a direct repair or a graft?
Generally, no. The outcomes from end-to-side repair tend to be less predictable and less robust than other methods, and it's not really used for motor nerves.
Okay. So once we've done the nerve repair, what does the immediate postoperative care involve?
Well, right after surgery, we need to protect that repair. We usually put the limb in a splint to keep the joints from moving too much and putting tension on the nerve. We also want to make sure the wound is healing well, so we'll check that within the first week.
Okay.
The splint is typically worn for a few weeks, and then we start gradually increasing movement. The exact timing depends on the type of repair and the location.
And rehabilitation is a big part of the recovery process,
Yeah.
right?
Oh, absolutely. Rehabilitation is crucial. Early on, it's about gentle movements to prevent stiffness and promote circulation. And as the nerve starts to regenerate, we focus on retraining sensation and motor control.
What does sensory reeducation involve?
Well, there are different stages to sensory reeducation. It often starts with desensitization, where we help the patient get used to different textures and temperatures.
So kind of retraining their brain.
Exactly. And then we move on to discrimination exercises, where they practice distinguishing between different sensations, like sharp versus dull or hot versus cold. And finally, we work on tactile gnosis, which is the ability to recognize objects by touch alone.
So it's a gradual process of regaining those fine sensory skills.
Exactly. And motor reeducation focuses on strengthening the muscles and retraining coordination and fine motor skills.
Now, sometimes, despite our best efforts, the initial repair doesn't go as planned or complications arise. What kind of secondary procedures might be needed?
You're right, sometimes a second surgery is necessary. One common procedure is internal neurolysis. That's where we go back in and carefully release any scar tissue that's formed around the nerve. Sometimes that scar tissue can compress the nerve and prevent it from regenerating properly.
So it's like freeing up the nerve.
Exactly. And in some cases, we might need to do a revision of the original repair or even do a bypass nerve graft if the initial graft hasn't worked.
Okay.
And then there are neuromas, which are basically painful nerve tumors that can form after an injury. If a neuroma is causing significant pain or dysfunction, we might need to remove it surgically.
So neuroma is like a tangled ball of nerve fibers.
You could think of it their way. And sometimes, instead of removing the neuroma entirely, we can try to relocate it, burying it in a muscle or bone to try to reduce the pain.
Interesting. So how do we assess the outcomes of a nerve repair? How do we know if it's been successful?
There are a couple of different ways to evaluate outcomes. One commonly used system is the British Medical Research Council, or MRC, grading system. It has grades from 0 to 5, with 0 being no movement or sensation, and 5 being normal strength or sensation.
So it's a way to quantify the recovery.
Exactly. And then there's a more detailed scale called Hyatt's method, which has been modified by Dellon. This scale breaks down motor recovery into grades from M0 to M5, with M0 being no movement and M5 being full strength. And sensory recovery is graded from S0 to S4, with S0 being no sensation and S4 being normal, including 2-point discrimination.
So those scales help us track the progress over time.
Absolutely. And it's important to remember that recovery can take a long time, sometimes up to a year or even longer. And the final outcome can vary depending on a lot of factors like the type of injury, the location, the age of the patient, and their overall health.
So it's not always a quick fix.
Definitely not. And for specific nerves, the expected outcomes can vary. For example, median nerve repairs at the wrist tend to have good to excellent results for both motor and sensory recovery. Ulnar nerve repairs, sensory recovery is often better than motor recovery. Radial nerve repairs, motor recovery can be a bit less predictable. And for digital nerve repairs, the results can vary depending on whether or not a graft was used, but we often aim for at least protective sensation.
So a lot of nuances. As we wrap up, what are some of the key takeaways we should remember about peripheral nerve anatomy and injury?
Well, first off, remember those anastomoses, those connections between nerves. They can make diagnosis tricky, so keep them in mind. And in many cases, a simpler epidural repair can be just as effective as more complex perineural repair.
Okay.
Avoiding tension on the repair is absolutely crucial. And if there's a gap larger than a centimeter or two, be prepared to use a graft or a conduit. Younger patients, early repair, and more distal injuries tend to have better outcomes. Immobilization followed by a dedicated rehabilitation program is essential for good recovery. And remember that sensory recovery often precedes motor recovery. Regular follow-up is key to track progress and address any issues that arise. And if motor recovery is poor, tendon transfers might be an option to help improve function.
Well, this has been a really comprehensive overview of peripheral nerve anatomy and injury. It's clear that managing these cases requires a thorough understanding of the anatomy, the physiology, and the surgical techniques involved.
I completely agree. And every patient is different, so it's all about tailoring our approach to their specific needs and goals.
Well said. We encourage everyone to continue studying this complex and fascinating area. This deep dive has hopefully provided a solid foundation.
And it's important to remember that research in this field is constantly evolving, leading to new and improved treatments for nerve injuries. Who knows what the future holds?
Exciting times. Thanks for joining us today. Until next time.
Thank you. It was a pleasure.